Hi, I'm Stacy Simmons. I am full-time faculty at the Capstone College of Nursing, and I'm also a pediatric nurse practitioner. And I often encounter Down syndrome children in my practice.
And my name is Cheryl Hines. I am an assistant clinical professor at the University of Alabama. I'm also a CRNA and have been for the last 40 years. And I too encounter a lot of people with Down syndrome in my practice. In fact, I'm seeing more and more as time goes by. So what we'd like to do today is review this topic and review how perioperative concepts can be a challenge for nurses in the hospital setting or in the outpatient surgical setting. And we're going to discuss the pathophysiology of Down syndrome, common comorbidities that you might come across, and how those comorbidities can have a direct impact on the perioperative setting. And then we're going to go through a case study, pulling all the information that we've provided for you and how that may impact the patient's perioperative experience. So 1 in 700 live births result in a person with Down syndrome. And historically, people with Down syndrome did not have a very long lifespan. In the 1930s, that was about 10 years of age. In the 1980s, that improved to about 25 years of age. And today we're seeing people with Down syndrome living with a life expectancy of about 60 years. And so if you look at 1 in 700 live births and a 60-year lifespan, that translates to 1 in every 1,200 people living in the United States having Down syndrome. And just by sheer numbers, the chances of a nurse taking care of a person with Down syndrome in the perioperative setting increases. So let's look at how this happens. How does Down syndrome happen? We have to go back, and if you'll advance the slide, we have to go back and look at cells in our body. And you have 2 different kinds of cells in your body. You have germ cells, which are your reproductive cells, and somatic cells, which is every other kind of cell that's in your body. And normally our somatic cells, or all the other cells in our body, have 46 sets of chromosomes, but your germ cells only have 23 chromosomes in them. Now, our little exemplar here, we've got sperm, but the same holds true with egg or sperm. And how these germ cells are created is through a process of reduction cell division. So we start with a parent cell, and we have our one big parent cell up here at the very top that divides into 2 daughter cells. And then the 2 daughter cells further divide into 4 germ cells. And like I said, these are 4 sperm, but it could very easily be 4 eggs if you're the female. And you end up then with 23 sets of chromosomes through this process of meiosis. Well, there are actually 3 pathways to Down syndrome, and we're going to take these one at a time, but they're non-disjunction, mosaicism, and translocation. So non-disjunction is the most common way for Down syndrome to occur. If you'll advance for me. There you go. And so what happens is there's a problem during that meiosis, during that cell division that creates the germ cells. Now, our example here on this image is that this is occurring on the egg cell, the egg side, but it could very easily, again, happen on the sperm side. And during that cell division, you want to end up with 23 chromosomes and 23 chromosomes, but you get an unequal division, and you end up with 22 chromosomes, which is a monosomy, and that is not compatible with life. So that is never going to make it to fertilization. Or you can end up with 24 chromosomes, and the 24 chromosomes added to a 23 chromosomes makes 47 chromosomes. And what's going to happen then with this person, every single cell in their body is going to contain these 47 chromosomes. All right, so that is non-disjunction. Let's move on to mosaicism. Mosaicism is very, very rare. And you know, a mosaic in art is a piece of art with different colors and different types of tiles. Well, in this case, we have different kinds of cells within the body because the problem with cell division occurs after fertilization. So we have fertilization and we have our normal 46 chromosomes. And then during that period of rapid cell division, something happens and we end up with 47 chromosomes. And that particular chain in cell division carries forward with the 47 chromosomes. But the vast majority of cells in the body still have 46 chromosomes, and a few have 47 chromosomes. So these are the people who have fewer individual characteristics of Down syndrome, but still have enough cells containing that 47 chromosomes, with the added chromosome being on the 21st chromosome to cause Down syndrome. The third way that we have potential for Down syndrome is called translocation. And to understand translocation, you have to understand chromosomes shape, and they're shaped like X's. And in the center of that X is a centromere. And in this picture, the centromere is in the center of the X, but that's not always the case. Sometimes the centromere is higher in the chromosomes and sometimes it's lower, creating a telomere or an arm of the X that's long or short. Now, sometimes in cell division, one of those telomeres will break off. And if it's the short arm of the telomere, again, that just kind of goes away. It gets reabsorbed by the body. It's not compatible with life. It just goes on, okay? But if it's one of those long arms of the telomere, that can actually move and relocate and reattach to a different chromosome. And that's exactly what happens in translocation. And usually when we're talking about Down syndrome, that arm of the 21st chromosome will break off and reattach, and it usually reattaches to the 14th chromosome. And it's this long reattachment added onto the 14th chromosome that creates the trisomy. So the cells will have 46 chromosomes, but on the 14th chromosome, it'll have that long broken off fragment of the 21st chromosome, and that's what causes the translocation, and then that's what causes Down syndrome for these people. Now, we're going to move and completely change gears now that we know how Down syndrome occurs. We have to start talking about the comorbidities that are associated with Down syndrome. And when we do that, I am a CRNA, so I live for airway. So that's where we're going to start, okay? And it's important to know that a lot of these individuals, and when you look at the literature, there's a wide variance in this number, that 20 to 50% of the individuals with Down syndrome will have cervical spine instability. Now, some of that can be caused because of C1 or C2 congenital anomalies. Maybe they don't fit and maybe they don't rotate on each other as well as we want them to. So you would have atlantoaxial or atlanto-occipital instability because of a skeletal issue. More often, it's because of laxity of the ligaments and muscles. And we have to understand that everyone who has Down syndrome has a little bit of muscular and ligament laxity. That's why when they're babies, you know, it's really hard for them to get that head lift, or, you know, you pull them up by their arms and their head kind of lags behind. So part of the problem is skeletal and part of the problem is musculo. But they do have that instability. So when we talk about coming to surgery in the perioperative setting, it's real important that we have to think about intubation. Now, with intubation, you know, you extend the head. Well, if you if you have laxity or instability there, you can really cause some spinal cord compression, and that's what you don't want to have happen. So you're really going to want to do, if you're the preoperative nurse, if you're the nurse checking the patient into the unit or checking them in for surgery, you're going to want to do a really good assessment of that C-spine. And you're going to ask about things like, do they have problems walking? Is there a problem with their gait? Do they have pain, numbness, tingling in their extremities? Do they have shoulder, arm, or neck pain? Look at them. Do they tilt their head to one side? And do they have weak problems with incontinence? All of those things, you're going to want to do a good assessment and get a good evaluation of that before you begin anything. Even if there are no abnormal findings, you're going to want to be careful with that intubation. And the circulating RN, like in the picture on the bottom, may be asked to provide it's called inline immobilization. And that's just a set of hands there holding the head and neck in a neutral position to prevent the anesthesia provider from really, pushing back hard on that head and overextending the person's head. The literature also says that if you might want to consider a fiber optic intubation, or you might want to consider a video laryngoscopy to accomplish this. But you want to be sure in the notes that you document that there was good head and neck alignment, not just with intubation, but also with patient positioning after the intubation. Now, your respiratory tract is not made up of just your airway, so we need to talk about respiratory tract. And this is important because Vita et al. In 2021 shared some research that showed that the leading cause of respiratory disease and that leads to mortality in Down syndrome, or respiratory disease was the leading cause of mortality in persons with Down syndrome. And if they do get a respiratory disease, this can lead to an ICU admission. If they do get admitted to the ICU, there's a pretty good chance, a 50% chance, that they're going to need mechanical ventilation. So what is the problem with Down syndrome in the respiratory system, and why do they have more problems with pneumonia and atelectasis and airway secretion clearance? Well, it has to do with congenital anomalies, and we have to first talk about obstructive sleep apnea. And people with Down syndrome have a predisposition for obstructive sleep apnea, again, just because of laxity of structure. When we talk about that, we say that they have a lot of malasias, tracheal malasia, laryngeal malasia. Malasias just mean they're soft and floppy. So in our upper image here, we see a normal larynx where it's nice and crisp and the structures are well defined. When you have a malasia, it's just soft and floppy, whether that's your larynx or your trachea, collapsing airway, you'll hear it described as that. All of that is the case. They also have problems with tracheal stenosis, a tracheal bronchus, where the bronchi comes off the trachea at a more acute angle. And all of that kind of sets them up for pneumonia, obstructive sleep apnea, infection, and all of those kinds of things. The American Academy of Pediatrics says the first line of treatment for children with obstructive sleep apnea is to do the tonsillectomy adenoidectomy. So you may see a lot of these children in your practice coming for their tonsil and adenoids. If they do, children with Down syndrome would fit into that high risk group. So a lot of them are obese, a lot of them have comorbidities, a lot of them have congenital anomalies, and therefore they would need to spend the night in the hospital. If you are in a hospital that is a children's hospital or children have a children's unit, that's usually not a big deal. I work at a small country hospital. We don't have a designated children's unit. So these children go to the surgical floor. So the nurses out on the surgical floor are going to end up watching these and monitoring that airway for 24 hours. And so you need to have an awareness of what's going on with their respiratory system. In addition to that, they're more likely to have problems with secretion clearance because of their cilia. And you'll remember your entire respiratory tract is lined by cells that have that little hair-like projection, that cilia that works like a vacuum cleaner to sweep debris and secretions out of the lungs. If I have Down syndrome, that cilia's motion is less and less frequent and less vigorous. So that also interferes with secretion clearance. As the person matures and as they age, I'm not the same as I was at 20. There's no reason to think someone with Down syndrome would be the same at 60 as they are at 20. So all of those things combined, where they started and as they age, it's going to lead to more problems with hospitalizations, respiratory infections, maybe some RSVs, and ending them up with some acute respiratory distress syndrome if they're not careful. Just a very brief moment about COVID, because the literature is divided about whether or not people with Down syndrome are more at risk from COVID, but you have to remember how COVID is associated with a cytokine storm. Well, here I am, I have Down syndrome, and then I already am predisposed to respiratory illness. As you age with Down syndrome, you're more likely to develop Alzheimer's disease, and Alzheimer's disease is associated with a pro-inflammatory state. So if I have Down syndrome, I'm 40 years old, I'm showing signs and symptoms of Alzheimer's, I am in a pro-inflammatory state, I come across COVID, I get the two together, and so your cytokine storm ends up being exaggerated and more. So the literature will say that you're more likely to get COVID if you have Down syndrome, but if you do get COVID and you do have Down syndrome, you're more likely to have trouble with it. You're more likely to have problems with the severity of the disease, which to my mind makes you a high-risk group. The other problem that you have are these subpleural cysts, and we'll see that on our lower image. These are just cysts that are existing all throughout our lungs, and those can cause mechanical compression of the alveoli, making them harder to expand and harder to get gas exchange. Also, if I have Down syndrome, gas exchange is a problem because I have fewer larger alveoli than the general population. So I'm already at a decreased surface area for gas exchange just by having Down syndrome. And we're going to move on to cardiovascular system.
All right, so another body system that is significantly affected by Down syndrome is the cardiovascular system. And so we know that about at least half of all the children that are born with Down syndrome will have some type of congenital cardiac anomaly. And you can see pictured here are the three most common types. That's your atrioventricular canal defect, also known as AVSD, atrial septal defect, and then your ventricular septal defect. Many of these cases will require either a catheter-based or a surgical intervention for repair. And if they do require surgery, most often that's going to be a cardiopulmonary bypass case. Because of the prevalence of congenital heart disease in this population, the American Academy of Pediatrics recommends that all infants born with Down syndrome undergo a screening echocardiogram to look for any of those anomalies. And any infant that has a known cardiac defect should be closely monitored for signs of heart failure. And those include tachypnea, difficulty feeding, and poor weight gain. Also, for infants with Down syndrome, the timing of their cardiac repair is typically performed earlier than non-Down syndrome children. And that's just because of their risk for developing irreversible lung damage and pulmonary hypertension. The perioperative nurse should assess thoroughly to make sure that a cardiac assessment has been performed in any person with Down syndrome and that any important lab work or reports are there on the chart. Also important to assess the severity of the lesion, the status of the repair, and if there are any residual lesions left over from that repair. And because children and adults with Down syndrome are more prone to having bradycardia. During anesthesia induction, it is recommended that they receive some type of anticholinergic drug, such as atropine, prior to induction. From a hematological standpoint, there are a few things that we should be aware of when we're working with Down syndrome individuals. Thrombocytopenia and polycythemia are commonly seen in neonates with Down syndrome. They might not be symptomatic, so it's really important that these infants have a full, complete blood count performed at birth. There is a condition called transient myeloproliferative disorder that affects about 10% of all Down syndrome neonates. And this is a type of leukemoid reaction that usually resolves on its own. But about a third of these kids may go on to develop leukemias later in life. So it's really important that they have that initial CBC done at birth. Signs and symptoms of this include bruising, petechiae, fatigue, and then changes in feeding patterns. As I said before, Down syndrome is a strong risk factor for developing childhood leukemia. They have a 20 to 30-fold increased risk of that as compared to the general population. But fortunately, about 2/3 of these cases will resolve. About 2/3 of these will occur before age 5, and their outcomes are generally good.
We talk about the GI system and Down syndrome. Just know that they have a tendency for atresias. So that's just a closed or absent orifice. So they may have a sphincter that's not open or a sphincter that doesn't exist. So they may have problems with obstruction, or they may have problems with reflux or something like that. Hirschberg's is also a genetic disorder that's a comorbidity. That's just missing nerves along a portion or all of the colon. So they're going to have problems with defecation. That's going to be an issue for them. And Gerd is very, very, very common. Again, and we're talking about the perioperative setting. All of these people with Down syndrome need to be treated as if they're a full stomach. So just like you would anybody else who has problems with GERD. So you may be asked to give some cricoid pressure if you're the circulating RN, or just know that that's going to be a possibility. And remember our problems with intubation. So now the circulating RN's role is really, really important when we're talking about taking care of people with Down syndrome.
Next, we're going to talk about endocrine and growth. So congenital and acquired thyroid disorders are common in the setting of Down syndrome, affecting about up to half of these individuals. Because of this, newborns with Down syndrome should be screened. And unfortunately, they don't always exhibit symptoms. So this screening should be done within the first 4 days of life. And it's also recommended that they have another screen or another check around 6 months and then at a year. And then throughout childhood and adulthood, they should have a yearly, no more than every 2-year assessment of their thyroid function. They're also highly susceptible to autoimmune disease. Some of those are Hashimoto's thyroiditis, Graves' disease, type 1 diabetes, and celiac disease. We know that people with Down syndrome will have a reduced growth velocity early in life. There are some thoughts as to why this happens. It could be related to feeding difficulty, thyroid dysfunction, gastric disease, or obstructive sleep apnea. Infants with Downs tend to be underweight, but as they get older and into adulthood, they can become more prone to obesity. And about 3/4 of adults with Downs are either overweight or obese. Children with Downs are also known to have some developmental delays. You can see here, there is a table that compares timing of developmental milestones between the Down syndrome individual and the non-Down syndrome child. You can see that that Down syndrome child is going to take longer to meet those basic milestones. They can have delays in language, motor, cognitive, and adaptive impairments. Intellectual deficits can be anywhere from mild to severe. about a third of kids with Down syndrome will have some significant behavioral problems like hyperactivity, impulsivity, anxiety, tantrums. They're also more likely to be diagnosed with autism spectrum disorder or attention deficit hyperactivity disorder. There are some other communication deficits that need to be addressed. So they can have hearing and language delays. Hearing impairment is very common in individuals with Down syndrome. And one cause of that is because of otitis media. They are definitely more prone to developing otitis, which can lead to some hearing loss. And so from a perioperative standpoint, the nurse needs to be aware of the impact that hearing loss plays in a Down syndrome person's ability to communicate, and also be aware of their general intellectual developmental level and how they can interact socially.
So let's just walk through a case study real quick to give you some practical application to everything we've learned today. So we're going to have Mary, and Mary is 25 years old. 3 hours ago, she was involved in a motor vehicle accident, and she was sitting in the passenger seat in the front seat. The airbag did deploy, but she really got slammed hard into that passenger side window. She broke her right hip. So she's coming to surgery for an open reduction internal fixation of her right hip. EMS put a hard collar on, a hard cervical collar on her because she was complaining of neck pain and hip pain, rating it as a 7 out of 10. And they did start a 20 gauge IV in her antecubital fossa, and it's running at normal saline 125 mils per hour. She is on home meds that include levothyroxine, famotidine, and a multivitamin. She has hearing aids, but somehow in the accident being, slung around a little bit, the hearing aids have been lost. She has had in the past bilateral myringotomy with tubes, so she's had some ear tubes. She's had the tonsillectomy, adenoidectomy, and she's had an EGD in the past just to confirm the diagnosis of reflux, but she had no problems with the surgery, no problems with the anesthesia, and she has no known allergies. So in the preoperative setting, it's going to be really, really important for that nurse to develop a rapport with Mary, to get her trust, because Mary is anxious, she's in pain, she's confused about what's going on around her. And so just get an idea of what's going on. Now, in our case, we're very fortunate that Mary's parent is with her. And so you can get a lot of information from that parent or caregiver. How do they usually respond to anxiety? How do they usually respond to pain? How do they usually wake up in the morning? Those kind of things are going to clue us in on what we can expect from Mary. It's also important to know as they age out of some of the treatment programs and care programs, if they get older and she's 25 years old, she may have aged out to a lot of things and just have a regular primary care provider. Well, like a lot of 20-year-olds and like a lot of us, if you don't have a problem, you don't go very often to your provider. So a lot of people with Down syndrome lack medical optimization before they ever come to surgery. So it's going to be real important for that preoperative nurse to look at any lab work that's been done, look at that C-spine series and make sure that it's been read, make sure that Mary understands with that informed consent to the best of her ability, and make sure that the caregiver understands what is about to happen and get that informed consent. In our case, the C-spine series is normal, within normal limits, and all our lab work is within normal limits. So the decision is made to replace that hard cervical collar with a soft cervical collar. And that was done just for comfort, because there is some neck pain. Mary is complaining of that. So the soft cervical collar, it feels better if you kind of immobilize a joint. Let's immobilize that joint and make it feel better. General comfort measures. Mary's assigned an ASA, that's the American Society of Anesthesiologists, ASA classification 3, because she does have some limits to her activity, but they are not incapacitating, and a Mallampati airway score of a 3. Just because of a large tongue, a lot of people with Down syndrome have a large tongue in relationship to a small mouth, okay? So she's been identified as somebody who might be a difficult intubation. And we also are going to leave that soft cervical collar on because for this procedure, Mary's going to need to be turned up on her side in a lateral position. And that's just going to help the circulating RN maintain that C-spine neutrality. In our preoperative setting, we also want to look at any medications, and we have to deal with anxiety. You have to decide whether or not you're going to give sedation. And if Mary is with her parent and she is cooperative, then sedation may be withheld because, again, I alluded to it earlier, people with Down syndrome tend to develop dementia and Alzheimer's earlier than the general population. And there's just kind of a general rule of thumb in anesthesia that you don't give benzodiazepines to older adults simply because it really scrambles their thinking. And so you want Mary to be able to go home. You want her to wake up oriented, alert, with it as much as she possibly can be. So, you might want to consider, what am I going to do? What kind of general comfort measures can I do? In Mary's case, it's decided to leave her in her preoperative room as long as possible with her parent, instead of going to a prep and discharge area or some other place to get checked in. Leave her with her parent as long as possible and just go from that preoperative setting directly to the operating room without the usual stop in between. Infection prevention is always a big concern of the intraoperative nurse, but we're going to talk today specifically. They are more prone to have respiratory infections, so you are going to do everything that you can to optimize that respiratory tract and make sure that you minimize any problems with pneumonia or aspiration. Wound infection in older literature, they state that people with Down syndrome are more likely to have problems with wound infection, dehiscence, and bleeding. The newer literature says once that you take into account the comorbidities and allow for that, there is no difference than the general population. But certainly in our case, we're going to do everything we can with the best sterile technique that we can to prevent a surgical site infection. We're going to give prophylactic antibiotics, and we're going to maintain normothermia. Hypothermia in and of itself predisposes any person to surgical site infection. So we want to maintain normothermia as much as we possibly can. We're going to watch our I&Os, bleeding, and we're going to do family education about what to look for surgical site infection. Then what we're going to do is decide, instead of putting in a Foley catheter like you might usually do when somebody comes in for an ORIF of a hip, we're just going to use a non-invasive female catheter, whatever you have at your institution. Mine carries the PureWick brand, but whatever type of female catheter that's non-invasive that your hospital has, that's what you're going to use. We had a successful intubation and induction, no big deal. We changed that IV from the antecubital fossa to someplace that's more convenient to Mary. We're going to keep that head and neck alignment. We're going to document that head and neck alignment. We're going to use hip positioners and, of course, our safety belt, and we're going to keep our patient warm intraoperatively. Postoperatively, and in fact, throughout this entire process, we're going to do really good communication handoff. And the AORN has very good guidelines about what should be included in that handoff. But every step of the way, we're going to communicate from preoperative to the nurse out on the floor about their respiratory system, about their ability to communicate, about their cognitive status, about their comorbidities, about how they handled certain things. And we're not going to have to reinvent the wheel every time we have a handover. If you have good documentation and good communication during that handoff, this information should be shared with every single nurse along the way, including, remember that preoperative assessment was, how do they usually manifest pain? How do they usually express that they're in pain? How do they usually manifest anxiety? All of those things need to be shared with the PACU nurse, but also with the nurse who's going to receive the patient out on the floor. And there are some differing studies about pain management. Some of the literature will say because they have fewer opioid receptors and because they have fewer neurotransmitters, because there are differences in neurological development, people who have Down syndrome it's hard to treat their pain. Others will say that's not so. So again, this is a place for the nurse to shine. Use your assessment skills, treat every person as an individual, and treat their pain as appropriate.
So in conclusion, Down syndrome is not just a pediatric condition, as you've heard. It's really imperative for the perioperative and the postoperative nurse to understand Down syndrome to positively impact their outcomes. Your role is critical. So understanding comorbidities and risk, performing a thorough exam and documentation, and then making efforts to optimize communication. That's with the patient, the family, and other perioperative team members. It's really important. The perioperative nurse's role is extremely important in communicating those aspects of communication. So we hope that you've enjoyed this presentation, and we appreciate your attention. Thank you.
Thank you.